Hi everyone, it's lovely to have you with us this afternoon, especially when it's so sunny outside. Just to let you know that the support service is available. It's 10 AM to 5 PM, Monday to Friday. So please do get in touch with us with any questions or queries or anything that you want to talk through. We are here to support you. It's me and my colleagues Annie and Catherine, and also Joe and Serica. So please do get in touch, and you can call us on the support line via email. There's instant chat through our website, there's text messaging, and we can also arrange a video call. So I'm delighted to welcome Professor Gordon Jayson to talk to us today. As many of you know, he's based at the Christie in Manchester, and he's going to talk to us about the effectiveness of bevacizumab, which is also called Avastin, as many of you know, and related trials. I will hand over to Professor Jayson.
Thank you very much, Alice, Anna, and also Victoria in Ovacome. Just going to share my screen with you all. So this is part of my lifelong attempt to convince everybody that the sky is always blue in Manchester. This is the Christie Hospital now. So I'm talking today about anti-vascular, which means anti-blood vessel treatments for ovarian cancer. And I'll just have a little bit of a background, first of all, on ovarian cancer. Every year, the illness affects around about 7,000 women in the UK. We know that the risk is in general reduced by pregnancy and through the contraceptive pill, and increased by age and family history. The reason that there is a link, it looks like, between periods and the reflux of the products of periods up the fallopian tubes onto the ovary surface after each egg is released and the woman has a period, and that somehow causes inflammation. And so when you have a pregnancy or contraceptive pill, that stops the release of the egg from the surface of the ovary, and that decreases the amount of inflammation around the ovary, and that seems to be associated with a reduced risk of ovarian cancer. We don't know the reasons and the mechanism of that, but it's a long-standing relationship that we know of there. One of the most important things to take home from today is that if a friend or a relative of yours develops irritable bowel symptoms, which means abdominal distension and discomfort, and they're aged over 50, and it's new onset and it worsens over weeks or months, that woman should go to see the GP and talk through as whether it could be a bowel tumor or ovarian cancer. And for ovarian cancer, you might need an internal ultrasound, what we call a transvaginal ultrasound, and a measurement of a protein in your bloodstream called the CA125. And that is one of the most important pieces of advice I can give today. If you know anybody who develops irritable bowel symptoms aged over 50, they should go and get it investigated. Irritable bowel is common in your teens and 20s, and that's normal. It's not normal when it comes on in the 50s, and that's usually when it needs to be investigated, particularly if it worsens over weeks or months. So, as I said, the standard investigations are an internal ultrasound and a CA125 measurement, and that then leads on, if the results look like they're worrying, to surgery and chemotherapy. So, the management of ovarian cancer, I'm going to summarize this today because today we're going to be talking about maintenance therapy in particular. Oops, sorry. So the surgery these days is performed by specialist gynecological oncology surgeons, not so much gynecologists anymore, but gynecological oncology surgeons, and they do the best operation. The operation is usually taken through a vertical incision, and that's so that the surgeon can see the top of your tummy and see whether there's any tumor deposits there that can be removed during the operation. But the surgeon will then try and carry out a hysterectomy, removal of the uterus, removal of the tubes and the ovaries, and the omentum and glands, as much, if relevant as well. And the important thing that the surgeon is trying to achieve is what's called a complete removal. And if they can do that, there's a good relationship between the amount of tumor that's removed and the future and the outcome for the person. So the more that the patient has removed at surgery, there's an association with a better outcome for that person. What we don't know is whether that relationship is due to the skill of the surgeons. In other words, a very skillful surgeon will be able to remove more, or whether it's simply due to the fact that a more aggressive tumor can cause more invasion or involvement of local structures that make it difficult to remove everything. So we can't tell the difference between whether it's a surgical skill or whether it's the aggressiveness of the tumor, but undoubtedly there is a relationship between how much tumor is removed and outcome for the future. So the goal of surgery is to establish the diagnosis, by which I mean the pathology, and work out the stage, which means how far it's spread. And these days, it's important to work out whether there's a BRCA gene abnormality, what we call a mutation, or whether the tumor is HRD, which stands for homologous recombination deficiency. And that means there's a particular type of DNA repair problem that means that the PARP inhibitor would be suitable for you. And I'm going to come through to this shortly. Where management becomes particularly difficult is in women who are aged, for instance, under 40, who might still be wishing to have a family. And the reason that's difficult is because the standard operation is a hysterectomy and both tubes and ovaries are removed, and that therefore removes the woman's fertility. And in certain cases, in young women, we can just remove one ovary, biopsy everything else, give some carboplatin chemotherapy, and try and maintain the woman's fertility. But it's always a very difficult issue to discuss the management of young women. So the conventional management, shown on the bottom left of your screens, is to do surgery first and followed by chemotherapy. But in many cases, because of the importance of trying to remove as much as possible, we need to give chemotherapy first, shrink everything down to make it easier for the surgeon to try and remove everything. And that's called neoadjuvant or preoperative chemotherapy. Then we do the operation in the middle and then finish off with chemotherapy. Chemotherapy tends to comprise platinum, of which the standard drug is carboplatin, and the other drug is paclitaxel. And that's given every 3 weeks for 6 lots of treatment. And if you have the operation in the middle, we do 3 before and 3 afterwards, roughly speaking. So now if you look at the bottom right, the combination of surgery and chemotherapy for the first line management of ovarian cancer tends to control the illness in around about 90% of cases. So the question is, how do you keep it like that? What can you do that is going to keep the illness under control? So this is going to be the main part of the talk today, and I'm going to focus on PARP and antivascular treatment, but mainly on anti-blood vessel treatment. Now, as you can see on the diagram on the left, a cancer or a deposit of a tumor consists of tumor cells, which are shown as the pink ball, with a blood vessel going into it, providing oxygen and food through the arteries, which are shown in red, and taking away waste products in the veins. So the blood supply is critical for tumors to grow. Not only that, the blood vessels are not only help tumors to grow, but they also enable, in some cancers, for cancers to spread through the blood vessels to other sites in the body in a process we call metastasis. So blood vessels are an important part of the tumor. Now, of course, there are other cells inside a tumor other than just the tumor cells and the vessels, but I'm just simplifying it for today that we're going to focus on those 2 features. Because if we can stop the blood vessels growing and we can do something about the cancer cells, then we can really start to keep things under control by potentially targeting both types of cells, the blood vessel cells and the tumor cells. So that's what we're trying to do in the current management of ovarian cancer. We give anti-blood vessel drugs, which I'm going to explain in detail to you, but we also give PARP inhibitors as well. And just to explain to you, if you don't understand about PARP inhibitors, if you look on the left-hand diagram, you can see the ball of cells that is the tumor that's growing. And then in the middle part of the diagram, you can now see a cell that contains a nucleus. And inside the nucleus are what's called chromosomes. And when you unwind those, that contains DNA, which is shown on the right-hand side of the middle picture. DNA is like a ladder structure, and it's the computer code that's inside our cells that tells our cells how to behave. In cancers, it tells the cells to multiply, perhaps in an out-of-control way. But cancer is actually a disease of genes. It's when the genes go wrong, and instead of the cells dying, they persist and they grow, but they're growing out of control. Now, we can take advantage of the repair mechanisms for DNA. As you can imagine, nature recognizes that DNA is really important. It controls all the cell behavior. So there's a number of different ways that our body repairs DNA to make sure that it's working properly to control our cells. And then in particular, there's one side of this DNA ladder that can be repaired by an enzyme called PARP. And then both sides of the ladder that I'm showing in the middle this DNA ladder, can be repaired by BRCA. And so you can see how these two work together. PARP repairs one side of the DNA ladder, BRCA repairs both sides of the DNA ladder, and they're both dependent on each other. So if in a woman who has a BRCA gene abnormality, then she's relying on PARP to repair her DNA. And we capitalize on this in our patients. So if the tumor has a BRCA gene abnormality, the tumor itself is incredibly dependent on PARP. And so if we take a tablet, which is known as a PARP inhibitor, the tumor cells are incredibly sensitive to that. And that's how the PARP inhibitor works. So we know that cancer is a disease of genes, but even so, the DNA has to be maintained. And the way that we take advantage of that is we know that BRCA and abnormalities like BRCA, what we call HRD, mean that there's an incredible dependence on this other molecule called PARP to repair DNA, particularly in the cancer cells. And so if we give a PARP inhibitor to patients who have a BRCA gene abnormality, we can actually kill the cancer cells and maintain control. So what this slide is actually saying to us is we can target the blood vessels and we can target the cancer cells. And by doing that, we can really try and keep the tumors under control once we've used surgery and chemotherapy. So we'll come back to this now. We're going to focus now on blood vessels. So this is a diagram of the anatomy of the ovary on the top left, and you can see the relationship with the ovaries to the womb and the vagina. And incidentally, you can see that the ovaries are quite high up in the woman's pelvis relative to the womb or the endometrium. So for instance, with endometrial cancer, you can develop bleeding as an early symptom. So in our patients, endometrial cancer, which is cancer of the lining of the womb, is picked up quite early. Whereas because the ovaries are a bit more distant from the outside world, it tends to be picked up later, and typically with a few months of irritable bowel-like symptoms, as the illness can spread to the local bowel and cause discomfort. Anyway, the reason I'm showing this is because the diagram on the bottom left of your screens is a cartoon of what an ovary goes through every month. Every month, your ovary produces at least one egg, and it starts at the sort of six o'clock position, if you imagine it as a clock, and the egg develops, and it develops within fluid, and that fluid is contained in what's called a follicle. And eventually that follicle just bursts onto the surface and releases the egg, which might be fertilized in the fallopian tubes to form an embryo that can then implant in the uterus and develop into a baby, or it's lost in menstruation. So the reason I'm mentioning this is the follicle that's formed, that is roughly speaking at the 4 o'clock position on this diagram, contains fluid. And the fluid that's in there is produced under the control of a growth factor, or like a hormone that we call vascular endothelial growth factor, which in other words is a growth factor or a hormone that makes blood vessels form, but it also controls fluid formation. And this is relevant to ovarian cancer because that same hormone produces the fluid leak that we get in some of our patients called ascites. So VEGF, vascular endothelial growth factor, is abbreviated to VEGF, is absolutely critical to the normal functioning of an ovary. And that's that reason this is a relevant system for us to look at for our patients. As I said before, eventually tumors grow from this small little dot of tumors that's like a millimeter, where it doesn't need any extra blood supply because oxygen and food just diffuse from local blood vessels into the tumor. But at some point when the tumor grows, it exhausts its ability to obtain oxygen and food by diffusion, and it develops what's called hypoxia, which means low oxygen levels. And when it becomes hypoxic, or low oxygen levels occur in the tumor releases this same hormone again, VEGF, to produce the picture on the right, where the tumor now has a blood supply. These blood vessels that have gone into the tumor enable the tumor to grow because they provide oxygen and food. And in some cancers, not so much in ovarian, they allow the tumor to spread to different parts of the body in this process called metastasis. So the point of showing you all these slides is to highlight that VEGF is essential for normal ovarian behavior and ovarian cancer growth, and therefore it makes it a really good target for treatment in our patients. So let me just show you the mechanism here. If you look at this diagram here, and just the writing in yellow is meant to represent the cell membrane. If you remember the cells that I showed you when we were talking about DNA, they're basically like beach balls, if you like, and this is the outside of the beach ball, the blood vessel cell membrane. And sitting in that is proteins that we call receptors, and receptors are just proteins that pick up the hormone, VEGF, shown in the middle here, and send a signal into cells to make the cells start to multiply. So our cells respond to hormones like VEGF by multiplying. So VEGF is a hormone that's released as a tumor grows, and it's designed to make blood vessels switch on and start multiplying to provide oxygen and nutrients. And we can try and block this process by giving an antibody to our patients, and that mops up the VEGF, and that antibody is called bevacizumab, or well known in the press as Avastin. So bevacizumab mops up the VEGF and stops it from activating the blood vessel cells. Now, we've been testing out VEGF and also tablet versions of VEGF that can work inside cells for some time. And we now know that these drugs work very well in multiple different settings. We've known for years, more than 10 years now, that these drugs work in the first-line setting if you give them with chemotherapy, with carboplatin and paclitaxel, and continue for a total of up to 12 months in the UK and in the United States for 15 months. And these treatments improve the outlook for our patients with advanced ovarian cancer. If you remember on the previous diagram, remember when I was saying that the tiny little dot doesn't have its own blood supply? Well, it turns out that if you've only got a little dot of tumor cells, it doesn't need a blood supply, and therefore these drugs don't work for patients who have very early, in other words, stage 1 ovarian cancer. It works in patients who have advanced ovarian cancer because they're the ones who need more blood vessels. And as I've mentioned already, these drugs work with PARP inhibitors in patients who have that sensitivity to PARP inhibitors. In other words, that BRCA gene abnormality or gene abnormalities like that, which we call HRD, are the patients who benefit from both treatments together. Now, before I move on, I've highlighted 12 months in blue because already there's a problem. If you think about it, why is 12 months the right amount? Why is 15 months the right amount? And some people have even looked at 30 months, but cancer works differently in different people. And so it's really important that we try to understand how long do these drugs work for, work in our patients? Should we continue them for longer in a particular patient or not? So what we need is a test, like what we call a biomarker, to tell us how long is the drug working for? Does the patient still need it after 12 months or not? And at the moment, the global licenses are up for 12 months in the UK, 15 months in the US, but no longer. And clearly, that's biologically doesn't make sense to us. It could be different for different patients. So we need to fine tune this to get the dose right for our patients. The next thing is that sometimes in our patients, the illness can come back after first-line treatment in the advanced cancer setting. So we've looked at this with this drug, bevacizumab, and we know that it actually postpones recurrence of the tumor. But what's even more important, and again, I've highlighted this in blue here, is it's not just that we can use it in the first-line setting or the second-line setting. In fact, for bevacizumab, the data suggest you can reuse it. So this is not available currently in England, and we need to try and do something about it. But it's not just you can have it once only. Clinically, the evidence suggests that you can actually reuse it and it still works. It's not like the PARP inhibitors, where if resistance has occurred to PARP inhibitors, it's not really clear that just using the same drug again is going to give you benefit. Whereas with this class of drugs, you can reuse them. It's just we don't have them available and we need to do something about it. Lastly, we can also use these drugs in platinum-resistant ovarian cancer. So there comes a point sometimes with some of our patients where platinum chemotherapy isn't so effective anymore. And again, we know that in that setting, say with weekly paclitaxel or weekly Taxol, that we can combine these drugs together. And again, it postpones the recurrence. Now, we don't have this available in England and Wales, whereas in Scotland, it is approved for use. And again, this is an important thing. We need to fine-tune the use of these drugs so that we can persuade NICE to support the availability of these drugs, just like we use with carboplatin. We can use carboplatin in many different settings for our patients. Similarly, with these anti-blood vessel drugs, they should be more widely available. We need to do something about it. So how can we make these drugs more widely available for our patients? Obviously, we need to advocate to NICE, but we need to identify the patients who benefit. And we need to improve the cost effectiveness of the drugs. And we need to do that by developing a test that tells us who benefits most of all, and that's called a biomarker. So years ago, when we were setting out on this program, which is between 15 and 20 years old now, we looked at the biology and we decided to look for any particular molecules that were relevant to the biology. So this cartoon is meant to show a growing blood vessel, which starts off as a stalk of blood vessel cells, which is what we're showing here. And we're showing a number of growth factors, of which vascular endothelial growth factor, VEGF, is an important one. But the biology of that is also linked to another blood vessel hormone called angiopoietin. And angiopoietin sends its signal into blood vessel cells through a molecule called Tie2. And it's Tie2 that I'm going to focus on today, because from our work, which we initially carried out in ovarian cancer, we showed in this diagram here that chemotherapy, which is shown in blue, does not really change the concentration of Tie2 in the patient's blood. But the patients who benefited, shown in red, who received the bevacizumab, had a decrease in their Tie2 level in the bloodstream. And when the bevacizumab stopped working, the Tie2 level tended to come back again. So what we're showing in this diagram is that we can tell from levels of this protein in the bloodstream whether the bevacizumab is working for the patients and when it stops working. And we did this through looking at ovarian cancer. Now, the field that I'm talking about, they're trying to find a biomarker to tell who benefits, has been fraught with false starts. We've had lots of people saying, yes, but there's this trial or that trial. So before we wanted to develop it towards the NHS, we wanted to confirm that this was the case. So we carried out a study in bowel cancer where we demonstrated the same thing again, that reduction in Tie2, just as you have in CA125, but this is for blood vessels instead. A reduction in Tie2 told us that the blood vessel drugs were working. And when the Tie2 levels came back up in the patient's bloodstream, that told us when the drug stopped working. And in the bowel cancer study, you can see this is a patient who had a liver metastasis from bowel cancer, and the redness reflects the amount of blood vessels in the patient's tumor. So in this trial, we gave the anti-blood vessel drug, and you can see that there's a decrease in the amount of blood vessels in the tumor between the left and the right figure that I'm showing there. And that reduction in blood vessels that we could see in the tumor matched up completely with what we were seeing in the patient's bloodstream with Tie2. And this told us, therefore, that this reduction that we're seeing in this protein in the patient's bloodstream was telling us that we were switching off the blood vessels inside the patient's tumor. So again, before we approached Cancer Research UK about this, we wanted to double check, because these two trials that I'm showing you, the ovarian and the bowel cancer trial, worked with bevacizumab, which is one class of drugs that blocks blood vessels. And there's another one, which is a tablet version of that drug called cediranib. And in this study, we looked at bile duct cancer, and we were able to show in that study, which was actually negative, this was a chemotherapy with or without the anti-blood vessel drug, but the overall study was negative. But by looking at patients shown in blue, who had a good reduction in their Tie2 levels, they lived longer, significantly longer than patients who were on the placebo. In other words, we were able to demonstrate that we could tell which patients that benefited from the anti-blood vessel drug, and they lived longer as a result of that. So we have 3 different cancer types, 2 different classes of anti-blood vessel drug, providing increased confidence that this is a valid test to tell who benefits from anti-blood vessel treatments. So we went to Cancer Research UK, and they were kind enough to fund this study, which is moving the whole project towards the NHS. So this is a study that's now open, and the study is called Valtiva, which stands for Validation of Tie2 for VEGF inhibitors. So because I look after ovarian cancer patients, I wanted to do this study in patients with ovarian cancer. So we're looking at patients who are eligible to have bevacizumab on the NHS in England, Wales, and Scotland. And they are patients who have surgery, chemotherapy, and bevacizumab. And we take bloods shown in blue before they start, and at 3 and 6 weeks and 9 weeks, and there's some other blood samples as well as they go through treatment. So it's nothing extra really for the patients to go through, because they're having standard treatment anyway. It's just an extra blood sample that's taken at the time that you have normal blood tests. And we're now developing a special protocol for those patients who will benefit from PARP inhibitors as well. The reason I'm highlighting this study, Valtiva, is to ask those of you who know anybody who has just had a diagnosis, that if you are diagnosed with ovarian cancer, it needs to be advanced ovarian cancer to be offered bevacizumab. And if you are offered bevacizumab, please do ask about entry into Valtiva, because Valtiva is the way that we're going to be able to convince the NHS to allow drugs like bevacizumab to be available, not just for 12 months in the first line setting, but also for women who have the misfortune for the illness to come back, and in the platinum resistant setting as well. We know that we can use these drugs, reuse them, and that 12 months in the first line setting is not really the best way of treating our patients. So we need to optimize this, and the best way is by developing a test that tells us when a drug is working, and that's what Valtiva is about. So for even the new patients with ovarian cancer, Valtiva, I hope, will provide information that we can use to persuade the NHS to make these drugs more cost-effective and more available for our patients in much better use settings within the first line, second line, and platinum-resistant settings. So we can take some questions on that later on. The question is, some of you may be thinking, well, hang on a sec, PARP inhibitors are around and VEGF and anti-blood vessel treatments are around. How do I tell which one I should have? Which one is better? And the answer is they're different. If you remember that diagram at the start, what I showed you was a cancer consists of blood vessels that are supplying blood and nutrients to tumor cells. Bevacizumab and drugs like it target the blood vessels and starve the tumors of oxygen and food. The PARP inhibitors hit the cancer cells themselves. So if we go back through my list again, first line treatment, we know now from a trial that was conducted called Paula-1 that patients who have either a BRCA gene abnormality in the tumor or in their bloodstream, or they have a weakness in the double strand repair, that means both sides of the ladder, what we call HRD, which stands for homologous recombination deficiency ovarian cancer. So patients who have HRD or BRCA are the ones who will benefit from a PARP inhibitor. And in the first line setting, we can now give bevacizumab with a PARP inhibitor. So the question is, if you're thinking to yourself, well, which one should I have? For certain patients, the answer is both in the first line treatment setting. Now, if the illness comes back in the platinum sensitive situation, for patients who've not had a PARP inhibitor before, then they can have a PARP inhibitor after their illness has responded to platinum chemotherapy. Where we're missing something in the NHS at the moment is that VEGF inhibitors, the bevacizumab anti-vascular drugs, they are useful and they can be reused. But PARP inhibitors, biologically, there's medically not a great reason to reuse them if you've had them in the first line setting and they've stopped working. We can come back to patients with BRCA in the question time if needs be, because there is a subgroup of patients who have BRCA gene abnormalities who will not have illness that breaks through a PARP inhibitor in the first line setting, where it might be appropriate to try it again if needs be in the platinum sensitive recurrent setting. Lastly, in platinum resistant setting, PARP inhibitors have not been particularly effective, and in that setting it would be more useful to have VEGF inhibitors. So VEGF inhibitors work in a number of different settings, in the first line setting with or without PARP inhibitors, in the platinum sensitive setting and in the platinum resistant setting. Whereas PARP inhibitors, you can't really reuse them if the illness has developed resistance to a PARP inhibitor, and they're not particularly effective in the platinum resistant setting. Looking at this conversely, if you remember that diagram I showed you at the beginning, where a little dot of tumor cells does not have blood vessels and therefore will not benefit from an anti-blood vessel drug, that is the case. But such patients may benefit from a PARP inhibitor because they still have tumor cells. So there's a logic to this. If a patient has blood vessels inside a tumor swelling, then they will likely benefit from an anti-blood vessel drug. PARP inhibitors work on the cancer cells, and we can come back to this again at the end. So the answer to the question at the top of the slide is, it's not a good question, because actually we can use them together. PARP inhibitors, you can't really reuse them if they develop resistance to the PARP inhibitors, because the acquisition of resistance means it's unlikely to work again. whereas there's not resistance to the VEGF inhibitors, and you can use those again in a number of different treatment settings. But there's no reason why you can't give PARP inhibitors with VEGF inhibitors together, particularly as we're doing now in the first-line treatment setting. Okay, so the point I'm trying to make, I've just highlighted it in the previous slides. If you look on this, on the left-hand side, tumors consist of blood vessels and cancer cells. Cancer cells can be targeted by the PARP inhibitors if the molecular biology is correct, and blood vessel treatment does not develop resistance because there's no genetic mistakes inside the blood vessel cells, so you can reuse those anti-blood vessel treatments. Okay, so in summary, what I'm saying is anti-blood vessel treatments, VEGF inhibitors like bevacizumab, they work in multiple different settings, but we really need to address this in the UK. They work in the first-line setting, but you could say 12 months, it doesn't make biological sense. Some women will need a shorter treatment, some women will need a longer treatment, and we need to understand how best to use that. And the Tie2 test that I've described is a way that we could actually improve treatment for our patients and fine-tune the drug for our patients. We know that the illness works in the platinum-sensitive recurrent setting and the platinum-resistant recurrent setting. And from a trial called MITO-16B, we know that we can reuse these drugs. In other words, if you've used them first line, you can still use them again second line, and they work again, whereas the PARP inhibitors do not necessarily work again, and that's why we're only using them once. Second paragraph, we need to make VEGF inhibitors available throughout treatment. And the way of doing that is through the clinical trial that I've mentioned. I don't want to say to you that they're always effective, and sometimes these drugs are contraindicated, which means that the evidence suggests they could cause you a problem. So in a woman who has advanced ovarian cancer, if the illness is pressing on your bowel, these drugs can cause bowel problems. So you have to be careful. You have to work with your oncologist about it. But we do need a greater availability of these drugs. In the same way that we can come back to using carboplatin for our patients, these drugs need to be made more available for our patients. So the question is, how can we do that? How can we convince the NHS that we want to make these drugs more available? And the answer is, if possible, patients who had the misfortune to just be diagnosed but are eligible to have bevacizumab, please consider taking part in Valtiva, or if you know anybody who's in that situation. There are 15 sites now across the UK that are taking part, and we hope to open more. And all it is providing a few extra blood tests that we're analysing in Manchester. And we hope that this will reduce the side effects for patients where the drug is not effective, and thereby improve the cost effectiveness of the drug, and hopefully convince NICE that we can make the drugs more available according to the clinical need. Thank you very much. I think you're silent, Anna.
Apologies, everyone. Thank you very much, Gordon. Thank you for flagging that nobody could hear me, and thank you for such an interesting and informative talk. We've had lots of questions come in, so I will read out as many as we can get to in the remaining 25 minutes. But just to let everybody know that Gordon's very kindly offered to answer any questions that we don't get to via email, and we'll circulate that to all the attendees afterwards. So we'll make a start. Is it possible to join the Valtiva trial if you've already started on Avastin?
Probably, unfortunately not, because one of the most important time points is the pre-treatment blood sample. Because it's like a CA125 in a way. What we're showing is we want to see a 25% reduction in Tie2 levels, and if somebody's already halfway through their Avastin, then that reduction, I hope, has already happened, in which case you can't tell. So we need a baseline sample prior to starting the bevacizumab.
Thank you. I've recently been diagnosed, question coming, I've recently been diagnosed with stage 4 high-grade serous ovarian cancer, have had first neoadjuvant chemo treatment. At what stage can I expect to be offered Avastin and ask for entry to the Valtiva study? Right,
so thanks very much for the question. Stage 4 ovarian patients with stage 4 are eligible to have bevacizumab in the UK. So the question is, at what point the oncologist feels it's safe. So as I said before, there are some reasons why you wouldn't start straight away. If a patient has a swelling, tumor swelling next to the bowel, there is a risk of possible bowel damage as a result of bevacizumab. And sometimes what we tend to do is to give chemotherapy first, bring things under control, and then bring in bevacizumab. And it might be that we bring in bevacizumab after you have your operation, what we call the interval debulking procedure, halfway through. So with stage 4 ovarian tumors, we would give chemotherapy first of all, bring things under control, hopefully aim for an operation, and then round about cycle 5, start bevacizumab. But you should ask your oncologist, first of all, when would bevacizumab be appropriate? And secondly, when it would be safe, and secondly, whether you could take part in Valtiva. We'd be very grateful.
And someone's asked, when are the results likely to come in from the Valtiva trial?
Right. So we're now developing, the first results are in patients who are not going to have PARP inhibitors, because we're going to open up a new cohort of patients, hopefully, who will be eligible for treatment with PARP inhibitors as well. The collection, the end of recruitment, I think, will be in about a year, and then we'll probably get another year after that. Bear in mind, we have other collections going on as well, and so we're working, we also have a Tie-2 collection and a trial called ICON 9, which is a recurrent ovarian cancer trial where patients are randomized after receiving chemotherapy. They have random allocation to either olaparib, which is the PARP inhibitor, or olaparib plus cediranib. And we're building Tie-2 into that, and that study is almost complete as well. So we have a number of different angles that we're approaching to try and push this over the line and get it into the NHS to enable the drugs to be more available. The answer is probably, I'm guessing, around about 2 years.
Thank you. Someone's asked if Avastin can be commenced in, I think BRCA positive stage 3C ovarian cancer after taking PARP inhibitors only for 6 months after chemo.
So bevacizumab works well when it's mixed with chemo and then continued afterwards. In the BRCA population, the results of SOLO-1 suggested that the patients with BRCA gene abnormalities really benefit very well from the PARP inhibitors. PAOLA-1 suggested that you might even get further benefit from both, but it's not really clear in the BRCA population whether having the bevacizumab on top of it gives you that extra benefit. We think it does, but it's still at an early stage. On balance, I think it's probably too late to start now, because you're already 6 months into your PARP inhibitor, and it would usually, the bevacizumab would usually have been started with the chemotherapy and then the PARP inhibitor brought in at the end of treatment. But for the BRCA population, we are sometimes just treating with PARP inhibitors only at the moment. There's one trial, as I said, the PAOLA-1 trial, that suggested there may be a superiority to at least bevacizumab by adding in the olaparib. What we don't know from PAOLA-1 is whether that population are just as equally well served just by having olaparib on its own. Can I just mention one other thing? I highlighted it a little bit during my talk. For patients who have no residual tumor with a BRCA gene abnormality at the end of chemotherapy, they're entitled to 2 years of olaparib, and then we stop. And we stop because of the risk of side effects by continuing for much longer. Those patients may never have developed a resistance. In other words, the tumor has developed resistance to the olaparib. And what we don't know yet, but have a suspicion, is that those patients might benefit in the future from PARP inhibitors. At the moment, the NHS doesn't support that, but the direction of travel is, if a woman has a BRCA gene abnormality, has her 2 years of olaparib in the first-line setting, and then has the misfortune that the illness comes back again, would she still benefit from PARP inhibitors because she never developed resistance to it in the first place? She had her 2 years and then just stopped it. It's a subgroup, a small subgroup, but it might be an important question for us to address in the future.
Thank you, Gordon. Someone's asked for low-grade ovarian cancer. Could it be beneficial to combine bevacizumab with tremetonib and fulvestrant as a frontline therapy, as opposed to chemotherapy, which isn't so effective for low-grade?
Yeah, that's a really great idea. Tremetonib, as you may be aware, is not the easiest drug to take. There's quite a lot of side effects with it in terms of rash and sometimes diarrhea. It's not the easiest drug to take, but it would be a really good study to do together. We know that bevacizumab is active in low-grade tumors, and I think it would be a very nice study to do. I think it would take a long time, so you might, it may take a sort of 10 years to actually answer that question. Logically, it sounds like a really good combination to bring together. I've thought about tremetonib and bevacizumab, but not with the hormone therapy as well. The trouble when you start putting 3 drugs together is you might see activity but then not know which one's actually making the big difference. So it's probably better to do a 1 versus 2 study in the first place, which might be tremetonib with or without bevacizumab.
And they've also asked, Avastin is already licensed for use with, no, I don't know this drug, alotinib, I think, as a frontline therapy for lung cancer. Could this existing combination also be worth exploring for low grade?
Alotinib, I'm not aware of the data on. Alotinib is an EGF growth factor inhibitor, epidermal growth factor inhibitor. So I'm not sure of the data that would back that up. I think our low-grade patients with low-grade tumors are underserved by trials at the moment because it's a rare tumor, but it has a very long outcome. So we do need new developments there. And I think tremetonib has been a development, but it's quite toxic. And I'm not sure it's that much, you know, it's not like bevacizumab where the main side effect is high blood pressure in 20% of patients. It's got quite a lot of side effects and some of the patients feel quite tired on it. But I think we need a greater push for low-grade tumors. They're biologically distinct from what I was talking about today, which is the high-grade tumors that are much, much more common. Low-grade tumors are rare, and we do need some research in them, but I'm not aware of alotinib really featuring there. I think, you know, a nice extension of where we're at would be to look at the MEK inhibitors, tremetonib, with or without bevacizumab, as the previous questioner asked. I'm not aware of alotinib. It was looked at in the 1990s and 2000s, and I'm not just aware that it would actually work in low-grade tumors.
Thank you, Gordon. And for platinum-resistant granulosa cell tumors, can Avastin be used for advanced recurrent disease? Yeah,
it can. The problem is they do work. It does work in these indolent tumors like granulosa cell tumors and low-grade tumors. It's not available on the NHS. So all of this underlines the importance of us getting a biomarker to make the drug more cost-effective and then pushing to make it available like this. When we, just in case you're wondering, can you do a individual funding request, what's called an IFR? The problem is that NHS England looks at situations where there's less than 20 cases a year. And unfortunately with granulosa cell tumors, they're rare, but they're not rare in my clinic. And so I don't think the IFR would be approved, but it would be a good treatment option to have available for our patients.
Someone's asked, how quickly do tumours start to redevelop blood supplies once bevacizumab treatment is stopped?
So that's a really good question, and there's some experimental data on this. The answer is quickly. So in experimental models, if you stop a VEGF inhibitor, that within days the blood vessels can come back, and that underlines again the inappropriate use of these drugs at 12 months. It doesn't make sense to stop because there'll be some patients, and there may be even people in the audience today, who've been on bevacizumab for 12 months, then it stops, and then the illness misbehaves. Or vice versa, it may not work. It may not work for the patient, but in any case, 12 months doesn't make biological sense. We ought to be tuning it to the patient, and by developing these tests to make it easier, to fine tune the drug for the patient. And when it stops working, do something else.
Thank you, Gordon. Someone's asked, can Avastin be used for premenopausal patients that have conserved an ovary, and does it impact on the functioning of the ovary temporarily or permanently? Yeah, so again, experimental models have shown that VEGF inhibitors in experimental models will absolutely stop ovarian function. The danger is if anybody fell pregnant in a premenopausal woman who fell pregnant on a VEGF inhibitor, it would be devastating because a growing embryo
by definition requires new blood vessels. So if we were giving an it would never be used, I don't think, in that setting. It would just be too dangerous to give something like that. It would almost be like giving chemo really to patients who are at risk of becoming pregnant. It's just a huge risk. So I don't think the drugs will ever be used like that because of the risk to an embryo. But the purpose of explaining it to you was that to show you that the normal biology of the ovary is dependent on VEGF, as is the cancer as well, and so it makes it a good target for ovarian cancer treatment. But there are other ways. So say in a patient with breast cancer, where you want to switch off the ovaries to protect them from the effect of chemotherapy, you can give other hormones that switch off the ovaries to protect the ovaries so that they're not in cycle at that time. So there are other ways of switching off the ovary with simple endocrine treatments that are already developed and available. I wouldn't go down the route of using VEGF inhibitors.
Someone's asked if the Tie2 blood test is available now to assess whether their bevacizumab treatment is still working, as her CA19-9 is still rising despite the treatment. So
yes, right. So if it's CA19-9 that's being measured, the patient probably has a mucinous tumor, which is a rare type of ovarian cancer. Otherwise, you'd use CA125 instead. The standard way of tracking this will be to have scans regularly. So you could say to your oncologist, if you're worried and the marker is going in the wrong direction, can I have a scan? So at Christie in Manchester, we would usually be scanning our patients every 3 months on maintenance therapy to track what's going on. Not all centres do that, so we're unusually intensive in doing that. But if you're worried, the Tie2 test, although it's being established at NHS levels in our hospital, it should still be viewed as a research tool. Despite the evidence that we've accumulated and are accumulating, it's still a research tool. So the standard answer to your question would be, if the marker's going up, hopefully your oncologist is onto it and will carry out a CT scan within 2 or 3 months of the marker going up. And then if the illness is playing up, you can switch treatments.
And someone's asked if Tie2 levels in the bloodstream are a better indication than CA125 levels.
Right, so what we've done with that, if you remember that diagram where I said that the cancer was made up of blood vessels, which you can track with Tie2, and cancer cells, which you can track with CA125, you can actually merge the data together. So what we've done in ovarian, yeah, we did it in all 3 trials. In ovarian cancer, bowel cancer, and bile duct cancer, we've shown that the cancer marker can be added to the blood vessel marker to give a much better understanding of what's going on inside the cancer. So just predicting ahead, that the idea that I've got for the future is that if you've got a marker of blood vessel behavior and you've got a marker of cancer cell behavior, and say we work out how to capitalize on the immune system for ovarian cancer, and you have an ovarian marker as well, you could start to model, you could start to track each of the different cell types inside a cancer and say, right, the blood vessels are misbehaving, I'm going to change the anti-blood vessel drug to something else, or the cancer cells, or the immune cells. And in that way, instead of things getting worse, which is what we do at the moment, tracking it on CT, you can pick up these different cells that are misbehaving and do something about it. But that's for the future. For the moment, the answer to your question is we can add Tie2 to the conventional marker CA125, and we get a much better understanding of what's going on. And that's useful for us for the future, not now, but for the future, because we can then predict when something's about to go wrong weeks in advance and do something about it before we lose control of what's going on.
Thank you, Gordon. Someone's asked a question that I think is probably following on from the answer about blood vessel regrowth. They've asked that they finished their Avastin in 2019 and CA125 level remains very low currently. Does this indicate that it's no longer the VEGF inhibitor that's preventing my cancer recurring? Yeah,
I mean, it sounds, thank goodness, like things are under good control. It will be out of your system. The half-life of Avastin is 11 days. So after 3 months, it'll almost be completely gone. Thank goodness the tumor is under control or gone.
Someone's asked if there are any trials women can sign up to once they have completed their first round of bevacizumab to receive continued treatment.
So the only thing that we have in the UK at the moment is called ICON 9, ICON-9 is this trial for platinum-sensitive recurrent ovarian cancer. So if the illness comes back, and there's been a good gap since first-line treatment, providing the illness comes under control with platinum chemotherapy, patients can then go into that trial, and 50% of the patients will just receive olaparib, which is the standard PARP inhibitor, and 50% receive olaparib plus cediranib, which is a tablet version of Avastin, effectively. And that we've built Tie2 into that as well. So ICON-9 is a study to look out for if you're in the unfortunate position of the illness coming back.
Someone's asked, they're BRCA1 positive, but also platinum resistant, which they understand is quite rare. And she thinks she could be wrong, but didn't think that combination was covered in the presentation. What's the best treatment for this situation? They've been on bevacizumab. Sorry to the person who asked this question, I'm just trying to limit identifying information. They've been on bevacizumab and it's being continued, and are about to reintroduce paclitaxel alongside it, and they've got advanced high-grade serous.
That seems like a reasonable option. So there are a range of different treatments. So let's just go back to the beginning. Platinum-resistant ovarian cancer means illness that has played up within 6 months of the last dose of platinum. It's a rough guide. It's not an absolute guide, but roughly speaking, that's where we detect resistance. And there's a range of different treatments that can be used. The gentler treatments, like for instance, Calyx, are not so active, but they can keep things under control, but they're less toxic. And as you start to increase the intensiveness of treatment, so you can go to weekly Taxol has a higher chance of bringing things under control. And from the sounds of what you just said, Anna, the patient's already on bevacizumab and they're adding in weekly Taxol, and that's a very good combination. That was highlighted under a study called Aurelia a few years ago, which showed that weekly Taxol plus bevacizumab is a good combination. And that's what I was getting at before when I was saying these drugs do work in the platinum-resistant settings. Then we in Manchester offer even more intensive treatments as well, which are called dose dense, which means weekly chemotherapy with platinum built in as well. So we give platinum on a weekly basis, be it cisplatin or carboplatin, with another accompanying drug that might be Taxol, gemcitabine, or in some cases etoposide as well. So these are more intensive regimens. They're more toxic, they're more active, if you see what I mean, against the tumors. But you have to balance the side effects of treatment against how well the person is and what problems they've had in the past. So for instance, if a person has bad neuropathy, numbness and tingling, it's a bit difficult to give loads of Taxol at that point. If they've had magnesium problems with platinum, that might divert you away from platinum, because magnesium is peed out in the urine in response to platinum. So there's a number of different considerations about what to do in the platinum-resistant setting.
Thank you, Gordon. We've had a couple of questions about clear cell, so I'll just ask them together. One was, does Avastin work in clear cell recurrence? And the other one was, what about treatment for recurrent platinum-sensitive clear cell? Is Avastin available on its own, or is there an additional drug as well as carboplatin? Yeah,
so clear cell is the type that's said to be a little bit more chemo-resistant, if you like, than the other types. And we have no reason to think that clear cell will be less sensitive. Remember that you're not targeting the tumor cells here, you're targeting the blood vessels. So the blood vessels tend to be sensitive to whichever tumor type. PARP inhibitors tend to be used for high-grade serous and endometrioid, but in the first-line setting, clear cell has been included with the niraparib approval. So you still treat clear cell cancer, and that may still be included in different clinical trials, and bevacizumab would work for them as well. So it's not a common scenario as clear cell, so it would need to be discussed with the oncologist. The problem is that we do not have bevacizumab routinely available in the NHS in the UK, and that's what I think today is about, is trying to develop a evidence base that would allow us to say to the NHS, right, we've made it more cost effective, we want the drug available now.
Thank you, Gordon. And someone's just asked about they stopped Avastin for a reason, and then they are asking about the blood vessel regrowth. And they've said, would restarting after 28 days bring it back under control?
So it would, but the license around the world is 12 or 15 months. And in the UK, we treat for 12 months. So what I'm saying, I've presented experimental data and 3 clinical studies today, but the standard of care would not necessarily be to restart it unless, well, first of all, it's not available to restart beyond the standard 12 months. That's the fundamental problem, is in the UK, we just don't have the drug available past those initial 12 months. In Scotland, they have it for platinum-resistant ovarian cancer. Restarting is not something that we can say is a standard of care right now. In the future, what I think we should be aiming at is to say, look, we can measure your Tie2 levels, we can tell when the drug's working, we can tell if the illness breaks through and develops resistance to it, so you should stop it and switch to something else. Or say a woman gets to the end of treatment and she has some residual tumor cells that you can still see on the scan, and therefore, if her Tie2 levels are still under control, continue the bevacizumab for longer. But we have to get this through the regulatory hurdles. We can't just do it, because many things in cancer medicine have seemed like a great idea, but we need to prove that it's the right thing to do first of all.
So someone's paused their treatment for 28 days. It would depend on sort of how far along they were in terms of how many months treatment they'd had.
That's right. So if you drew an analogy, some patients, for instance, in the first-line setting, will have 1 or 2 cycles of Avastin pre-op, then have surgery, and then restart afterwards. And they will need to stop the Avastin for about 6 weeks before the operation and 6 weeks afterwards. So in a sense, they've had a 3-month break in the middle of their Avastin, and that still works okay. So you can have a small break, but what I'm saying is the NHS right now will only fund a total of 12 months of treatment. And we have to try and change that, but we have to do it on the basis of evidence.
Thank you very much, Gordon. We're almost at the end of our time. I'm sorry to anyone who didn't get their question asked, but as we mentioned, we will get back to you. Because Gordon's very kindly said that he will reply, and we'll send him all the outstanding questions via email. Gordon, was there anything that you wanted to say before we finish at all?
No, I'm really grateful for you inviting me and for everybody listening today. And as I said, the best way of improving the lot for any of our patients with ovarian cancer is actually, if you can, to encourage people to take part in Valtiva, so that we're completing this pathway set out by Cancer Research UK, so that we can then move to the NHS and NICE to convince them to make the drugs more available for our patients.